Okay, we'll go ahead and get started and people can trickle in as we start with some announcements and then introductions. Masood, do you want to go ahead and kick us off?
Sounds good. Yeah, thanks, Dr. Autry. Thanks, everyone, for joining, taking the time to be here today with us. We're going to go ahead and get started. Just a reminder before I share the screen, I see a lot of you have already done this, but be sure to go ahead and just rename yourselves on Zoom. If you haven't already, just put in your full name first and last, and then your organization name. That helps for attendance. And then I'm going to go ahead and get the presentation shared for everybody. All right, everyone can see all right? Presentations there? Yep. See some head nods, thumbs up. Very nice. Cool. Well, welcome everyone. My name is Masood. I'm one of the project coordinators for REACH, and I'm going to be filling in for our other project coordinator, Maggie, today, who normally does these introductions. So today's topic is going to be management of respiratory symptoms with Dr. Emma Jones. Welcome everyone again. We're just going to go over a few housekeeping announcements and initial disclosures before we go ahead and get started. So for initial disclosures, basically your individual data is going to be kept confidential. We use the data for reports, maps, communication surveys, quality assurance, evaluation, and to inform new initiatives. For educational purposes, we will be recording the session and it's going to be available on our website for all of you as participants. And then by participating in the session, you are consenting to being recorded, and we highly value your participation in anything that you want to contribute during the call. And if you have any questions or concerns, please feel free to email our other project coordinator. Her email is listed on the slide right here, maggie.palapoli@lcmchealth.org. So LMHPCO is accredited as a provider of nursing continuing professional development. So we are able to provide CEU credits to those who are interested. You basically just complete an email survey after this session in order to get the credit, and you should receive the survey via email no more than a week after this webinar. So yeah, feel free to participate, complete the evaluations, and then just keep track of how many sessions you're attending. Zoom etiquette, so everybody just want to keep on mute when you're not speaking, and then remember to unmute yourselves before you start to speak. Speak closely and clearly to the microphone, and we love to see everyone's faces if possible, so please feel free to keep your camera on if you're able to. And again, if you have any IT issues, feel free to just leave that in the chat and we can try to take care of that, or you can send an email as well. And then again, just a reminder, please be sure if you haven't already to just include your first name and your last name, as well as the organization that you're working with. And you just do that by going to the three dots on your small screen in the Zoom, finding yourself and choosing rename. If you have anything that you want to communicate during the sessions, feel free to raise your hand by clicking the raise your hand icon or using the chat as well. This is a safe space, so all of your thoughts and questions are valid and valuable, and we appreciate everything that you want to say. And then what's said here stays here, like Vegas. So we protect the privacy of everyone in here, and we keep everything confidential. When sharing real life examples, be sure to only share de-identified information as well. And with that, I'm going to turn it over to Dr. Autry, our facilitator, to go over the agenda.
Hey everyone, wanted to go ahead and start with introductions. See a lot of familiar faces, both from our hospital and previous sessions as well. We'll start with the REACH team first. So I'm Dr. Autry. I'm one of the pediatric palliative care physicians here at Children's Hospital in New Orleans. I did my training at St. Le Bonheur and St. Jude and Memphis, Tennessee, and then started my career here at Chilnola, and I've been here almost 4 years, which is crazy. And I have partnered with St. Jude to get this curriculum together for all of us over this next year. Masood, do you want to go next?
One more.
Masood.
One more. Okay, got you. Sorry.
Oh, sorry. No, sorry, not next slide. Like you go next introducing yourself.
Oh, got you. Okay, yeah, sorry about that, guys. Hey, my name is Masood Rezvani. I'm a practice administrator here at Children's Hospital New Orleans. I help support the palliative care team. I am one of two program coordinators alongside Maggie, and I'm filling in today. Yeah, just super excited to be here. So I'll pass the baton over to Dr. Emma Jones.
Thank you. Hi, I'm Emma Jones. I am the speaker today, and I work currently at Care Dimensions Hospice in the Greater Boston area, where I am the medical director for adult and pediatric hospice and community palliative care programs. And I was previously working in Louisiana at Our Lady of the Lake as a HEMONC physician at the St. Jude practice. So some of you may have crossed paths with me there. Speaking of that, I will have Katie go next.
Hi, I'm sorry, I'm waiting on IT to come and try to fix the video, but my name is Katie Hilo. I am a pediatric nurse practitioner here in Baton Rouge at Our Lady of the Lake Children's Hospital, where I split my time between the St. Jude affiliate clinic, where I do pediatric HEMONC, and then around half of my time is spent inpatient doing palliative care. So work closely with hospice in Baton Rouge and some other outlying hospices. But yeah, really excited to be here, and we miss you, Dr. Jones. Come back.
Hey, Katie, thanks for joining.
Hey.
Stacy?
Did you say Stacy?
Yep, sorry.
Hey, that's okay. Stacy Melling. I work at Children's Hospital in New Orleans. I'm the integrative therapy nurse, work very closely with the palliative care team. Those patients are always our first priority. Doing, decreasing the stress and the worries of the patients and working with non-pharmacologic symptom management and just an advocate and liaison for our patients and families. Mostly palliative care, patients who are on the palliative care service. Thank you.
Thanks, Stacy. And then I see Christy introduce herself in the chat. She's one of our pediatric consultants and nurses at Heart of Hospice.
Hi, everybody.
Judy, you want to go next?
Hi, I'm Judy Zarang. I'm nurse at Children's Hospital, and I continue to be very passionate for pediatric palliative care. So I'm really happy to support this program. Thank you.
Thanks, Judy. Cheryl?
There I am. So I'm Cheryl Churn. I'm the MFM nurse navigator for LCMC. So I work with all the high-risk mother-baby dyads, getting them through their prenatal care and delivery and follow-up.
Thanks, Cheryl. Cindy?
Hi, I'm Cindy Fowler. I'm sorry, I don't have video right now. I'm Cindy Fowler. I am the director for St. Tammany Parish Hospice. And I started off my career at Children's in the PICU and as the pulmonary nurse coordinator there. But I am doing mostly adults over here now. We're trying to venture into peds.
So exciting. So glad to have you.
Thanks.
And Tammy?
Hey, I'm Tammy Ide. I'm the manager of supportive care services with the palliative care department in the Baton Rouge region.
Perfect. Okay. Did I miss anyone? I think that was everyone. Okay. Next slide. I think is our objectives. Yes. So today we're going to discuss common respiratory symptoms, including sialorrhea, which is increased secretions, cough, dyspnea, short of breath. And then we're going to review treatment approaches for each of these, both thinking about underlying causes, goals of care, and then non-pharm and pharm therapies or treatment options. Next. I kind of
I
talked
just
about
wanted
it.
to let you know.
Yeah, go ahead.
Ashley, I'm gonna hop off video for a minute so y'all don't have to watch me eat lunch.
No problem. I did the same.
All right.
Okay. Wait, Go back, Masood. I think that's good. Go ahead. I kind of already gave like an introduction for sialorrhea, increased secretions, which is obviously something we see a lot with our neurology patients, and at the end of life. Next slide. Is this Emma's is it going into the presentation already?
It just started.
I thought there was like a slide that introduced you. We might have skipped it, sorry.
It's all
Go
right.
back.
Let's begin at the beginning.
Okay, I just reviewed the objectives and now I'm gonna let Emma go ahead and dive into each of these objectives for our didactic portion. Thank you, Dr. Jones, for joining us.
Thank you so much. Yes, definitely happy for people to be off camera if they're eating or driving, but then on camera if possible. This definitely can be very interactive. It's a small group and we only have 3 symptoms to talk about, so we have plenty of time. And I'm pretty non-threatening. So raise a hand or just unmute and I'll notice. I can also monitor the chat. And I will also thank you for your grace in advance. I'm on call and we have a patient who's kind of melting down right now. So if I have to break, I know you will all understand, but I hope that doesn't happen. All right, so respiratory symptoms, we all think of dyspnea, but I think this is great that we included sialorrhea and cough because they do come up very distressing. So just before we start, does anybody have kind of like a patient in their mind when we talk about these symptoms? Have you had somebody recently that you were struggling with one of these, or it could have been a long time ago? Sometimes they stick with you. We will do cases at the end, but I want to just hear if anybody kind of has anything that came up when we just introduced the topic. Nope. Never seen anybody with it. Okay.
I feel like we have that. I feel like it's almost like that for every patient with us. Like when I feel like almost every one of our patients, it's like, you know, something with their airway, secretions. Do they get a trach? Do they not get a trach? Like I feel like it just seems like it's a common thing. Maybe not for every patient, but for a lot of our patients, that's what I see.
Thank you for saying that. I do think these are incredibly common symptoms because, I mean, as we all know, you know, I mean, I know a lot of y'all may be adult. I'm not sure what people's experiences are. If you have a lot of experience taking care of adults, you certainly see excess secretions at the very end of life, right? Like it's one of our hallmark symptoms that we're in the last days, hours to days of life. So we certainly see that's very, very common, if not universal symptom. But that also, as people are getting weaker and they're less able to swallow, this is going to become more and more of an issue for them. So almost everybody has to go through that phase on the way to the end of their life. So of course, these are very, very common symptoms. The approach that we're going to take for each symptom is the approach that I would take, and I think that this curriculum probably recommends for every symptom, is first, take a holistic view of like what's going on. Second, think of it in the context of goals of care, and then do a broad spectrum approach, which includes non-pharmacologic and pharmacologic treatments. Okay, next slide. Oh, there goes my phone. Let's see if they can wait. All right. Sialorrhea, fancy word for too much secretions, right? Drool, which becomes a problem both because it's messy, but really then it's an aspiration risk. That's why we really care about this. But certainly it can be a problem. Kids can get skin breakdown. They can get rashes, you know, like there can be multiple problems from this. Most common in children with neurologic impairment, because their swallowing is impaired, or children with abnormal airways or aerodigestive system, right? Like if everything's not connected properly, of course, you're not going to be able to get the spit. That spit is made in your mouth and meant to be swallowed and go down into your stomach. So if anywhere along the way that's not in continuity, you're going to have excess secretions, which is one of the reasons why we see it. Or if you have weakness, which is the other reason why we see it. And then of course we talked about this as the end of life symptom. Everybody knows what this symptom looks like, right? I think this one's pretty intuitive. We know what this looks like. Next slide. So then when we think about the causes or the differential, what are we thinking about? Some of the stuff I just talked about as you're kind of like working your way down. That's kind of my approach. I don't like to memorize stuff. I like to think about it logically, like what could go wrong? Why is this happening? So a lot of the things that we talked about, maybe they're making too much, right? That could be another reason. Either fluid overload is one thing we want to think about. Are there just too much fluids everywhere? Or is this patient due to some nervous system dysregulation actually overproducing, like too much parasympathetic tone, right? Like making too many secretions. Could there be an infection, right? That would be more mucus, snotty stuff than clear secretion. Would look the same, right? Like full drippiness. Allergies and asthma, same thing. Medication side effects due to that parasympathetic tone, and then too much fluids, right? So those are the kind of main ones. Any others that aren't on here? Any other causes that anybody can think of why there may be kind of too much secretion going on? So then this is also going to start to build our case of like, what are we going to do about it, right? So really, when you're taking that history, you're both looking for these reasons, and then you're looking for what's modifiable. Some of these things are not going to be modifiable, right? Like we cannot make their airway in continuity if their airway is not in continuity, or we cannot make them have more neurologic tone, or maybe we can, right? Like let's think about why is their neurologic tone poor, like neuromotor tone. Why is that poor, and can that be modulated? What meds are they on that we might think are to blame, and can those be stopped or changed? Maybe not. That's why goals is going to be the next question. And then when we're doing physical exam, what kind of things do you think we're paying attention to when we're doing an exam for sialorrhea? No. Somebody say something.
I guess looking at the secretions as well in terms of thin, like viscosity, thin or thick, or obviously color doesn't predict infection, but or bleeding, or just kind of analyzing the secretions as well.
Yeah, good one. That's perfect. Look at the snot itself. The snot, is it saliva? Is it blood? What are we working with here, right? That's helpful. Obstruction, right, it is part of the differential. So maybe like, is there something shoved up their nose? This is more gen peds stuff, but I mean, remember, kids on palliative care have gen peds problems too. So do they have a Mardi Gras bead in their nose? And then the after effects, how do the lungs sound? How do we think we've had an aspiration event, or is this real upper airway? What's the skin looking like? Like how much complication are we having? You can feel like, parotids are here. If they have like parotid hypertrophy, that might kind of give you a different differential than not. But mostly it is kind of like examining the secretions is probably where your money's going to be. And then the overall picture of what this patient's condition is going to help you put the picture together. Okay, next slide. Okay, so then when we're thinking about goals and why goals-based care planning is important for this symptom, what are the main things? Somebody already mentioned trach, right? So are we gonna instrument this airway, or is this airway already instrumented? And that, or do we need to take that away? Like those are things that, particularly because we're talking about an airway, are going to bring up goals-based decisions. What other sort of like give and takes might come up when we're thinking about sialorrhea? Judy?
One of the things may be how far along are we in the process, and what goals do they have? For instance, if they are nearing end of life and they are on feeds, perhaps we begin to reduce those feeds, giving them the anticipatory guidance that they are not going to require as much feeds.
Love it. So yes, fluid overload or directly aspirating feed are two of the things that might be causal. And if we're prioritizing respiratory comfort then we may want to cut back or stop feeds. So that would be a goal that, you know, I mean, again, that's a medical recommendation. We're saying it's harming you. And so we would like to stop this, but we know that because feeding is so goals, it feels so goals oriented. Even if we're saying like this feeding is harmful, that often comes off as a goals based conversation. So knowing where their goals are, knowing where they are in the trajectory of illness, knowing what their prognosis is, right? Are we months? Are we days? Are we hours? That's
Yes.
going to help you figure out what you want to do. And then I always like to think about too, you know, which side effects are more tolerable, because, you know, I always say, you know, there's no such thing as a free lunch. If I'm going to do pharmacologic, that's going to have some side effect. And so we have to just think about for this patient and for this family, if we're trying to walk the tightrope, which side are we more comfortable falling off on, so to speak. And, you know, specifically with sialorrhea, usually the trade-off is thick, hard to clear secretions or too many thin secretions. And, you know, we're trying to kind of tread the tightrope on that one. But stopping the feeds is the biggest one, or thinking about the trach. Those are probably the two biggest goals-based things come up when we have this symptom as the top prevalence. Okay, somebody was asking a question.
It's Christy. I was just saying I have a good example of the goals and what they want and have in mind. So last night I got a call from one of my moms that they're transferred to the North Shore, and she called and was like, this is what they said. What does this mean? A disintegration of his disease and this, that, and the other. And so it was all the fact of, after we got through everything, does he have pneumonia that we can treat? So I told her to ask the nurse out there to do a portable bedside chest x-ray. Or is this something that he's going to have? And she was telling me how she felt like she was feeling changes and things were not right. And it was, if it's something we can treat, we're going to treat it. But if it's not, she wants to take his end of life care into her own hands so that she can do it the way she wants. And she wants to go back to Chinola and have him pass there and withdraw all support, because she wants to donate what organs that he has to other children. So I think it's really important to listen to them and fully hear what they want. And that way we can advocate for them, with them, and help support them.
Thank you so much for sharing that. I mean, that's a lovely example. That's a common goal that so many of the families we have, right? Fix what you can fix, and then be honest with me about what we can't, so that I can focus intensively and exclusively on comfort. We are always attending to comfort. I don't like to say comfort care plan, because like that seems like we're not always having comfort, but I do make it clear when we are focusing sort of exclusively on comfort, that is a little bit of a different phase, and that we do hear that from people. I mean, I work with adult patients who don't want their goals of care to not do anything that would prevent their death or prolong their life. So, you know, it's not that everybody wants to treat everything, even that's treatable. It's worth asking the question. Sometimes you've entered a phase of quality of life that even not treating treatable things, in terms of like infections, I think that we want to make people as comfortable as possible. So we want to get our treatment plan for sialorrhea going, if that's a primary symptom that people are dealing with. And we're going to come back to that case as we talk through cough and dyspnea as well. So thanks, Christy, for sharing that. Next slide. Okay, so again, working our way through, think about the differential, think about the goals, and then do a non-pharmacologic management. So maybe that's cutting back feeds, maybe that's suctioning, maybe that's repositioning, doing airway clearance, whatever you can do to make that more comfortable for the patient. Sometimes just getting it to flow is fine. You know, sometimes it's easy to deal with if you could suction it out. That's going to depend on the patient. But think about what you can do to solve it in a somewhat like mechanical manner. That's really what the non-pharmacologic for this is. I don't know that I mean, Stacy, you can tell me, is there any integrative therapies or non-pharm stuff that you would think about doing for this symptom other than these?
I always think of, and maybe you can talk about this, just from my days of being on the floor, I think, why don't we just give everybody Robenol? Is that something that we don't use anymore? Does it slow down other things?
All right, great
But I
question.
do think that, I just think of, positioning, reminding parents that just because, I mean, it looks sometimes really gross, but if we put the gauze there and keep lots of extra padding of gauze and remove it, sometimes it looks gross, but if the patient's not in a lot of distress, I saw a patient the other day, she's got so many secretions, she literally had bubbles, but she was comfortable. So do you go in every 2 seconds and suction them? Maybe you don't have to, because we're just doing it for aesthetic reasons. So
Yes.
that's really,
Thank you very much. We're going to talk about meds in just a minute.
okay.
Robenol's still on the list, but like I said, no free lunch. Suctioning, I will talk about suctioning. Mouth suctioning, probably not as big of a deal. When we're talking about trach suctioning, there is definitely such a thing as over suctioning. I mean, you all have these families that are constantly like going in there for everything. That will irritate the airway and cause it to produce more secretions. So it like creates a cycle. So I really often have to do a lot of education to tell people, I know every time you see a bubble, you want to like suck it out, but it's actually counterproductive. So please stop doing that. And then the positioning is a lot of trying to protect the lower airways, right? Like secretions up here are annoying, but not really life-threatening. When we're getting down into the airways, that's when we're setting up risk for pneumonia. So doing the chest PT and airway clearance maneuvers so that when those secretions do get down in there, they can clear them out is also important. Next slide. Let's talk about meds. Okay, so here's what we have. Kind of one thing if your secretions are too thick, and then a couple of things if your secretions are too much. So if there's just sort of clogged up thick secretions, doing a normal saline neb to kind of get it flowing is our main trick. And then basically on the other side, everything is anticholinergic. So we're just trying to shut off saliva production is the main mechanism of action for how all of these work. That's what glycopyrrolate, which is Robenol, scopolamine patch, atropine, or hyoscyamine all work through anticholinergic mechanism. The botulinum toxin is kind of combo because we like inject that directly into the parotid. So it like paralyzes them so they can't secrete. So that's a little bit different. That's obviously an invasive procedure, but is very effective for some people. And then there's actually a surgical procedure. You can actually tie off the parotids or sclerose the parotids as well. Those are invasive things that ENT can do for kids who have lots and lots and lots of secretions. I will say that in my practice, I see a lot of kids on Robenol chronically for secretion management. And then in the end of life setting, I tend to use atropine. That's just my preference because it's a small volume and I feel like it's just so easy to have in a comfort kit and it's easy to be around. But that's really for those imminent end of life secretions. I don't tend to use that. But I will say, just in terms of framing this for your staff that might be covering pediatric patients, I know in our agency, when people see hyoscyamine or Levsin is our formulary choice, like that's what comes in our kit, that when our nurses see a patient on that, they kind of like their mind is trained to think that patient is within hours of death because they're using it for terminal secretions. And so I really have to say, no, if you see it in a kid, if you see any of these drugs in a kid, that doesn't necessarily mean they're dying like imminently. It just means they have too many secretions, and that trying to train people that we use these as more of a chronic med than just that really end of life symptom, which seems to be different than the way that they're used in adult patients. Any questions about the meds? No. Dealer's choice for which one's which, like which one you choose. I would go by like how you're trying to dose it, right? The practicalities. Like if I'm putting this in a G tube, I need something that's kind of like more volume. If I'm putting it in a mouth, I want the most concentrated, lowest volume thing. Patch, I feel like scopolamine patch is like just a mess for everybody because then people touch it and they're spreading it, and sometimes they're more trouble than they're worth. But if you want to set it and forget it, go with the patch. But again, like practical reasons why you would choose one or the other, there is no good data for like one of these is better than the other one. Trial and error. And if you try one, it doesn't work, try a different one. Okay, next slide. Okay, cough. I'm just gonna go a little faster because same principle. All right, again, when we're thinking about cough, we start with, why is this patient coughing? What's going on? What's the history of the cough? When did it start? Does the history suggest this patient aspirated on something and has a foreign body in their airway? Does it suggest they have aspiration pneumonia, they vomited or gagged on something and then started coughing? Does this suggest regular, community acquired pneumonia or viral? Reflux is on the list. And then of course, medication side effects. What are our kind of like main meds that we might think about? These are more commonly used in adults, but there's one class of meds that is kind of like the board's answer. Anybody know? We might see a kid on it. ACE inhibitors. So, but this is the trick on meds. It's going to correlate in time. You don't have to be that smart. Just say, oh, look, you started coughing. Did we add any new meds within the past week or 2 weeks? Then that might give us a clue that that was related. If not, it's probably not related. So that's good. Cancer patients, when we're thinking about cancer patients, they may have airway or lung tumors that are irritating and causing them to cough. So that's certainly part of the differential, and you can investigate. The oncologist probably going to tell you. They probably know where the patient's disease is. But if they don't, or if a patient's been home for a while and not coughing, then all of a sudden it's coughing. That's always my question. Do we know if this patient has lung disease or not? And if we don't, then maybe we want to find out. You can also do physical exam to figure that out. What might we be looking for if we have a tumor blocking the upper airway? What's that going to sound like on exam? Stridor, right? So like that kind of like whistling
It's
in
gonna
and
sound
out.
like a croup.
Yeah, croup,
Yeah.
cough, or like a whistling sound. Whereas lower down in the airways, you might hear wheezing or you might hear crackles. Maybe they're gonna have fluid. But kind of all those, you can help localize a little bit. These are not super specific physical exam findings, but you can, do some things to try to help you guess about where things are. And this is often what we have to do in the hospice setting. We don't have imaging, maybe not based on goals, which we'll get to in the next slide. Maybe not. Are we going to go do a CAT scan and see where the tumors are? Maybe we're just going to have to listen and say, oh, wow, I saw you a month ago and your lungs are pretty clear. And now I'm listening and you're like whistly, crackly, wheezy all over both sides. I think we've had quite a bit of progression in the pulmonary metastases, right? Like that's kind of how you might line that up. What does that mean? Why do we want to know? Maybe that's going to be prognostically significant. Maybe that patient might start having more respiratory symptoms soon. Or maybe that's going to help us think about our treatment plan. For a patient with neurologic conditions, our sort of chronic complex care type of patients, they often don't have a lot of cough because cough actually requires a lot of neuromuscular tone. So that's sort of the opposite problem. You rarely hear people talking about cough in a neuromuscular patient or in a patient with severe neurologic impairment. It's that they can't cough. So we're having to do all those things like the vest and like the cough assists and like the, manual chest PT because they don't have a good cough. Not always, but as a paradigm. All right, next slide. Okay, so again, pretty much same things we're talking about in goals of care. Are we going to treat a pneumonia if we have it, or are we going to treat infection if we have it? Is respiratory support within goals of care temporarily or permanently? And what does this cough mean? What is this cough interfering with? And then are we ready for some of the treatments that we might be using? This is kind of one of those pings that I send out because opioids are on the list of things that we use to treat cough, and they're certainly on the list of things we use to treat dyspnea. So starting to feel that out, right? Like, what does it mean to this family that I'm going to recommend morphine for this problem? I tend to say morphine in, that means any or opioid, Dilaudid, oxycodone, fentanyl, whichever one we're going to use. Just for the sake of ease, I will generally say morphine. All right, any other thoughts about goals of care specifically around cough? I feel kind of like the goals around respiratory symptoms are all kind of the same goals. Okay. Cough, one of the things that comes up specifically with cough is that it interferes with sleep. So I'll hear that as far as like teasing this symptom out separately from some of the other respiratory symptoms. We need to treat this cough because they won't sleep, which I totally agree with. I mean, sleep is very important. But that's not really goals based, but maybe just kind of like a nuance of the symptom. Okay, next slide. All right, so non-pharm, pretty much the same stuff that we did for sialorrhea. Try to keep the airway clear, use saline nebs if needed to kind of help clear, or use the patient, if they have lung disease, they may have other nebs that they use, either albuterol or Atrovent or whatever it is that's in their kind of airway clearance regimen. Optimize that, right? Like max it out. Let's make sure we've got all the gunk out of your lungs, if they have it. If they're too dry, humidify, right? So whichever way you feel like you need to go. And then thinking about irritants is certainly another good thing, that if there's poor air quality or a lot of pollen. I mean, we had wildfires recently up here in New England and the air quality was really poor. I know that we were sending a lot of our patients air purifiers for the patient's room for those days that we had the smoke in the air and that kind of thing. So those are all important things. If there are other irritants like smells, right, or whatever seem to be triggering the patient, trying to remove that. Most hospitals and facilities are scent free specifically for that reason, but in their own home, they may not think about, oh, sister's now burning this new candle she got, and oh, all of a sudden you've been coughing, maybe saying, put that in the other room, or at least trying it. So thinking about those kinds of things. And then cough can have a little bit of a habitual component. So if there are patients that are, more cognitively intact and they may be in a cycle, right? Where like there was a stimulus, but then they cough and they cough and they cough and then they kind of get in the habit of coughing. You can address that with non-pharmacologic, kind of more CBT type of things, or maybe distraction things, to try and like break that cycle, right? Like you don't have to cough for 20 minutes because you felt a little tickle in your throat. Like what else can we do to clear that out? Kind of approach can be good if that seems to be, again, your history and your evaluation will reveal that. I certainly don't mean to say that children with lungs full of metastases have habit cough, but you can have some element of it, and that addressing that can help relieve the symptom. Okay, next slide. Okay, and then for pharmacologic management, obviously if it's secretions that are dripping down and they're coughing those up, use the secretion management that we just talked about. Treat infections if they're there and within goals to treat. Again, thinking about the causes, right? If you think it's reflux, maybe it's a trauma, maybe you don't know, right? We're not gonna do any like invasive diagnostics necessarily to prove that this patient has GERD. Doing a 2-week trial of medication may be diagnostic and therapeutic. So that's a fair thing to do. We talked about the NABs, and then cough suppressants. There are generally no good cough suppressants. This is like Gen Peds thing, right? Like none of the stuff that you buy off the shelf actually works. The way that we suppress your cough is by suppressing your cough, which I would say opioids are the only thing that really do that. Now I've totally allowed people to have placebos. So if they want to take, guaifenesin, dextromethorphan, Tessalon Pearl, whichever one they want to take, that's actually probably not that great, they may still help because it helps reduce some of that amplification element, right? Like, oh, I'm taking this thing that's helping my cough. Well, it'll help the part that you can control. But there's not really any good ones. Just as a public service announcement, I think this has fallen out of favor, but always just say no to codeine. It's terrible. So no cough syrups with codeine. I would much prefer just use morphine, right? The reason my codeine is bad is because it relies on metabolism for activation. So the drug that you ingest is inert, and then it has to be activated in the liver in order to be the opioid substance. And that there's a lot of differential metabolism. So some people do that really slowly or not at all, and some people do it really fast, and you have no idea what the person sitting in front of you is. So why would we want to do that? Just don't give them the pre-morphine that has to go through this crazy black box and maybe get turned into a lot of morphine or maybe get turned into a little morphine. Just give them morphine, and you can give them just the right amount. And that, right, like we can dose morphine on a wide range. So a little bitty dose of opioid can be a wonderful cough suppressant in the palliative care population. I think the risks of opioids are too great to justify that as a recommendation for well children, like Gen Peds population, but in the populations we're treating, I think it's a really great option, particularly if the cough is bad enough that it's interfering with sleep. A low dose opioid would be perfectly justified. Next slide. Okay, and then dyspnea, where we're really going to get into using the opioids. So dyspnea, again, our fancy word for shortness of breath or the feeling of like not being able to catch your breath. It's a terrible feeling, right? Like this is a terrifying feeling of not being able to catch your breath, and something that certainly is intuitive, would lead to a large burden of suffering, no matter when you were encountering it. We talk about it in our setting because we kind of intuitively feel in, we are not, this is dyspnea that is not going to be relieved by respiratory support, right? So like if an asthma patient is dyspneic and can't breathe and feels terrible, they're going to get intubated or they're going to get on BiPAP or something like that, right? Or if you have pneumonia, like in an otherwise healthy patient, you're going to get technological support to get you through that episode. So the management of dyspnea in that case, they're going to do the same care plan, right? Same exact care plan. What's causing it? Okay, we know. What are the goals? Do whatever it takes to survive this episode. So then what's the care plan? Provide intensive support so that this patient's getting the ventilation that they need. That's one end of the spectrum. That might be the care plan that a lot of the patients who are in our programs choose, right? We have patients that live on chronic ventilation. So in those patients, they may have sick day settings. What's the right answer if they feel dyspneic? Turn up the ventilator. I think that for today's purposes, we're kind of thinking about the patient that isn't that, right? They're not really, the answer to their dyspnea is not turn up the respiratory support, because either that's outside of goals or we have exceeded the respiratory support, right? There are patients, you guys can probably think of them, I've seen plenty, even on sort of max vent settings, still dyspneic. And so then what do we do for those patients? Next slide. Here are kind of main contributing factors that we might be looking out for when we're doing our history and physical exam: pain, fatigue, volume overload, infection, secretions, anemia, anxiety, certainly lung disease, like at baseline, intrinsic lung disease, could all be contributing factors. The interplay between pain and dyspnea is always fascinating, as well as anxiety and dyspnea, right? Because then they sort of drive each other. Luckily, the meds that we use overlap and treat both, so you don't necessarily need to sort it out. You can get on the right path relatively quickly. Let's talk about the treatment plan for this. Next slide. So what are the goals? We talked about all of this, basically how much respiratory support is within goals, and is treatment of infection within goals. Next slide. Non-pharm things for dyspnea. The big one that we always want to remember is airflow directly to the face. This kind of stimulates some of the reflexes we have, primitive reflexes, that airflow coming onto your face kind of settles your nervous system and makes it feel easier to breathe, right? That's not oxygen, that's just flow. So that's why fans are super helpful. Repositioning is don't miss it, right? If their airway is obstructed, we want to relieve that depending on what they might have, particularly if they have tumors or an abnormal airway. It may not be the position that you think, right? So like this is what we learn in like BLS is like open the airway, but maybe for this patient that has tumor here, like this is an open airway, or you know what I'm saying, just use your eyes and ears and figure out what the best position for the patient is. Cool room. And then dyspnea is where a lot of the integrative therapy techniques can be really, really helpful because of that sort of cycle, amping up effect that can happen, that if you can wind it down, that you can at least, you're still probably going to reach like a baseline level where you need some pharmacologic management, but you can wind down some of the extra stuff that sort of comes on top of it, right? The worry about what does the dyspnea mean, what then makes it even feel like more tightness in your chest and more I can't catch my breath and all of that. So using the relaxation and breathing techniques, guided imagery and those kinds of things. And then generally just anything that can keep the patient in a more relaxed state most of the time is going to be beneficial as well. Okay, next slide.
Dr. Jones, could I say something about that really quick?
Please do.
One of the things that when we tend to want people, when they're having dyspnea, right, they're getting anxious and even if their stats are high, they're still anxious and they feel like they can't breathe. And what we tend to want to tell them is slow down, calm down, take a deep breath. And they're panicking and they can't, right? They just can't. One of the things that is helpful is if you just teach patients to blow out, and they can pretend like for kids, pretend like they're blowing out through a straw, but just ask them to empty their lungs. If they empty their lungs, the air will just then tend to flow back in. So get just shifting their mind to thinking about just empty all the air and then just let the air flow in. So they're not so much trying to take in that deep breath. Does that make kind of sense? It's just kind of a brain trick to get them to think about it a little bit differently, or maybe not think about taking that deep breath as much.
Yes, that's beautiful. Thank you. I use that trick all the time. I do think that focus on your breath when you can't breathe is actually not going to be helpful.
Yeah. Another thing that I do, and I've been teaching the nurses this a lot, is to remind them, we can tell someone to calm down, but they don't know what that means. And to just remind them, feel the bed under you.
Yeah.
Feel where your head is touching the bed. Feel where your shoulders are touching the bed. Feel where your legs are touching the bed. And if they can start to do that, they're thinking about something else. And then try to empty your lungs of all the breath.
I love that. Thank you.
And some people probably do that naturally.
My, very unsophisticated technique is the birthday candle. I have people blow out the birthday candle. With little kids that works, but even teenagers will do it. They think I'm kind of hokey, but they'll do it. Yes, and then anchoring, right? So what Stacy was describing of feeling something else is just a way to like mind anchor to something else, not the sensation that you can't breathe. So I love that. Do not try to explain to someone the philosophy of what you're doing when they're in the middle of a crisis. That's never going to work. Just get them to focus somewhere else. No different than if you were in like a rough and stormy sea. I don't want the physics of why an anchor works. I just want my boat not to fly away, right? Like drop the anchor, learn about the physics later.
But remembering too that what I've seen, and I've seen this a couple times fairly recently, that the staff, when a patient is panicking, the staff also panics. And so I do try to remind the staff, like, look, just take a deep breath. Because if they go in, I saw this recently, they're like telling this patient, you need to calm down. They're standing there all looking at her going, you need to calm down. You need to calm down. That doesn't help. So I'm like, maybe if we have less staff, we can remind ourselves to take that deep breath or blow out the candle ourselves and bring
lower
some of
the lights, put on some nice music, whatever that means to the patient, right? Just like make the environment nice. And
screaming at them that they need to calm down is usually never going to work.
Not usually.
When my kids, when they come up to me and they're like, chill, mom, not going to probably chill right now, dude. Right.
Christy,
another good trick that you can do to make it fun, like with the straw, and you can get them anywhere, like at Dollar Tree right now with the summer. Like I have a couple of them in my car. It's the little pinwheels that you put in the yard, and try and make them blow it and make it spin as fast as they can, you know, so that makes it fun for them of any age, you know, just have them do it, make it like a contest type thing.
Yeah.
And it gives them something like a toy or fun to use and interchange with.
I love that. Thank you. Any little knickknacks you can carry in your bag. You have the little coping kit at the ready. What a nice thing to have. Okay, next slide. Great. All right, and then when we're getting to pharmacologic, you can get a long way with non-pharm for dyspnea. I do think it really is very powerful between the fan and then some of these mindfulness techniques. We can do a lot, but not all. Sometimes that can't cover the whole thing. Or maybe people just can't access it. You know, we need a little bit of everything. We need to take the edge off with some meds, so then you can access some of that stuff. So it's opioid is the main answer. If the opioid is not working, if you give a small dose and it doesn't work, you need more. Don't say, oh, morphine didn't work for this patient's dyspnea. You just didn't give them enough. We do general guidance is that 1/2 to 1/3 of the starting dose for pain is the appropriate starting dose for dyspnea, because you can often get away with less, and the right dose of opioid is the minimum amount that achieves the desired effect. No matter what you're trying to achieve, the minimum amount that does it is the one you want, but you don't know what that is. I think that's what we have to admit. Just because we're starting at that low dose doesn't mean that's going to be the right dose for that patient. We still have to titrate up until we capture the symptom. And that there is often pain too, right? So, you know, knowing that, oh, this is the dyspnea dose versus this is the pain dose, that just gives you a starting place. Just make sure that you're continuing to go up. Benzos can be helpful as adjuvants, but I definitely would not use benzo alone, because that really doesn't provide that kind of real relief that the opioids use. But often, because that agitation and worry about the symptom kicks in, that using both can be helpful. And then, you know, I like that we consider oxygen a drug here, because it does have pluses and minuses. For many patients, it's going to be within goals to go on at least nasal cannula oxygen or face, you know, blow by oxygen. And then whether more invasive things or more like kind of support, like a high flow or non-invasive ventilation is within, that has to be within goals. It also has to be within tolerability. Like, I mean, I have a patient right now I'm thinking about, the family would like to support her breathing, but every time you put the BiPAP on the kid's face, she's like losing it. And so then that doesn't win us anything, right? I mean, we can work with psych to try to get her to have tolerance for it. She's incredibly neurologically impaired, so that, you know, I'm not sure how successful we're going to be with behavioral techniques, but, you know, like that's just it's not necessarily a goals-based decision. It's like you tried it and it didn't accomplish the thing you were hoping it to accomplish. So you have to kind of take a different tack. Because having to sedate her so that she can tolerate having the BiPAP on her face may not win us anything in her overall quality of life and comfort. So you just kind of have to think about that all in together. But there are other patients who do use in non-invasive, say at nighttime while they're sleeping, and that provides them enough support that they can coast during the day. And then those patients may have a good quality of life or extend their life for several months because of that, and that may be very within goals of care. All right, next slide. Okay, so what concerns do come up when we talk about opioids? I sort of mentioned like this a little bit earlier, like how people react when you say morphine. What do you guys hear, or what do you feel, or what do you worry about? I'd say I imagine you hear it from families.
We usually hear, you know, why are you giving him that? It's gonna make him stop breathing. Like, you can't give him that.
Yes, exactly. Respiratory depression is a big fear people hear. People think it's the death medicine, right? Because they've had a family member that was on hospice and, you know, or died somewhere and they got morphine before they died. So that was what caused it. or even just that it means that we think they're in the last days of their death, and you're only supposed to take morphine if you're within the last days before you die. So if we start the morphine, that must mean that you're dying, right? Like that sort of like backwards logic kicks in. Ashley, what were you gonna say?
Substance abuse concerns. I think for patients who aren't at the end of life, parents worry about the damage that will be caused in the future, or their kids getting dependent on the medicines a lot.
Yes. That is, and that's, I think a real concern that we need to speak to and would be part of that goals-based conversation. Obviously, probably a little bit more pertinent to pain. I think if you can't breathe, we need to, but I mean, everything's on the table, right? There's never a right answer. There are just shades of like, which problem are we more comfortable with? Nothing is perfect. There are no free lunch. You're in a shared decision-making situation with that family, assessing their goals and values, and then putting that together with your content knowledge to say, okay, this is going to be the best plan that achieves the most of your goals, right? That's our whole job. That's what we do. But yeah, I think we have to speak to the respiratory depression one the most often in this setting, because we are kind of saying we want to shut down your nervous system a little bit, just not a lot bit. So that's the answer, right? Like we just say it's dose dependent. And that's the easy answer. Obviously the communication skills and art of medicine kicks in on how you actually message that to families. But the truth is, who has seen a patient on at least 10 milligrams of morphine every 4 hours still breathing? Right? Still breathing. Who's seen a patient on 10 milligrams IV morphine an hour and still breathing? Right? Like we have evidence, we have seen it that patients can be on a lot of opioid and continue to breathe. We have this like deep ingrained knowledge that this is not true, that just because you give a patient opioid, they're going to stop breathing. Other people don't have that. Other people have never seen a patient take opioids before, or maybe the only people they've seen take opioids did die for one reason or another. So I think keeping that in context, but the piece that I need us to be willing to do is to dose appropriately. I think that the biggest sin that we can commit as care providers is to be timid about pushing the dose to capture the symptom, because you're afraid you're going to make that patient have respiratory depression. There's always a continuum. If you escalate gradually, the patient's going to get sleepy, then the patient's going to breathe slower, then the patient's going to have apnea. They're not going to go from like breathing 50 to apneic unless you increase the dose by some inappropriate increment. So what's an appropriate increment? 50 to 100% in the Emma Jones book. I'm very aggressive. So if the dose you're giving right now is 10 milligrams and that's not working, they're still dyspneic, you can go up to 15 or 20 milligrams as an appropriate step. You cannot go to 100 milligrams as the next step. You cannot go to 2 milligrams, like that's the wrong direction. And I would say go into 12, like adding 2 if they're already on 10, may not be enough for them to feel a difference. That's why I say 50 or 100%. 30, I'll give you 30. Like if you're trying to like finesse it and the family doesn't want to go up that much, sure. I mean, I break my own rules all the time. But, just to say, when I'm saying if you make appropriate increments, you're not going to make a patient apneic, those are the increments that I'm talking about. And I bet that feels really aggressive to most people that are listening. So that's what I have to say about that.
So I follow that rule very strictly, but when I recommend it to physicians, I've often met with, first of all, they look at me like I have 2 heads. And then it's usually followed by like, we can't do that. And so then they increase the PCA or the dose by hardly anything. And then I'm the one in there watching the patient still suffer. And it's like, how do you work to change that culture? Like what key words do I need to be using? Because clearly it's not working.
So some of it is just, you can just talk science, right? Like this is why I talk in percentages, that, in order for it to be an appreciable difference that can be felt by the patient, the minimum increment is 30%. If I increase by less than 30%, that's just not going to be pharmacologically significant, right? And I would like you, if you're talking like ICU doctors, use words like pharmacologically significant. You could even say pharmacokinetics. You know, just so it's like I'm not just wanting to jack this up just because I think this patient needs to be less alive, right? Like that's what they think we're doing.
Right.
We want to make this go faster because like we're impatient or something. I don't know, like have they met us? We're the most patient people. But that's what they think, right? So that's okay. Don't speak to that. Just talk to them on their level, like about the science of it, and the increments is what, and like, just say like, I know these numbers get big, but everything has to be relative to like where to itself. So if we were starting from a big number, of course the increase is going to be a big number because it's 50% of that or even 30%. The other trick that I use is that the smaller I guess the smaller or the bigger, but typically the smaller the increment that you're going up by, the more frequently you have to titrate. So if you are going just up by 1 every time, 1, 2, 3, 4, then you need to be reassessing that patient every hour, right? To see if it was effective, or maybe even every half hour, because like, it's not going to work. You're not just going to give them that weenie dose and then say, oh, I'm coming back tomorrow to see if it's working. No, like go back and see. And then the proof is in the pudding, right? Like if you said, Dr. So-and-so, she's on 10 milligrams an hour and it's not working. I want to increase the drip to 15 milligrams an hour so that we can get good control of this patient's dyspnea. And they say, you're a crazy person. I'm definitely not doing that. I'm going to increase it to 11. Then go back and however long, say just increase the drip without a loading dose. They'll never get to a new steady state. So again, try to explain to these people how pharmacokinetics works. But let's just imagine they did that appropriately. But like you go back and you just say like, well, look, like we increased it. They're still dyspneic. Their respiratory rate is 50. This isn't working. Can we go up a little bit more? And just keep doing that. Again, you're patient. You keep doing it as many times as you need to until you get to the right dose. That's what I would do.
Thank you.
Any other questions? These are great. We have cases, but like you guys bringing up your real world stuff is what I really want to talk about. So, and then when does this part end, Ashley? How are we doing on time?
We have plenty of time. Maybe another, Stacy, 5 minutes or 10 minutes for mindfulness.
I can go as fast or slow if we need more time. I was thinking probably today about 10 minutes.
Okay, so we have another 10 minutes, Emma.
But I can shrink it to 5. I can go fast.
It's experiential. Stacy, I want you to have plenty of time. It's experiential learning for how to reduce our own dyspnea and tachypnea. So I'll say that. Let's make sure we have enough time for that. Okay. Any other questions or thoughts?
Question. So we recently had a patient, he was 15 years old, multiply relapsed Ewing's, and came back to us from hospice, wasn't comfortable at home with hospice, came back in. It took a while to get him comfortable, but we were able to get him comfortable. And the family's there, everyone's kind of said their goodbyes and everything, and the doctor was like, well, do we take off his oxygen? Like, he's clearly declined. We were kind of stuck in what to do, and when we would turn down the oxygen a little bit more, the families would make comments, so we were educating on that. But I really kind of wanted to know how y'all handle when they're on some oxygen. That's kind of the last, I guess, things. Like my thought was, I really would love for this mask to not be on his face, so his mom can kiss his face without it on him. But also realizing I want the family to be comfortable, and I realized that could look like I'm taking away his oxygen and then he takes his last breath, and it was something I did. So I just didn't know if you've experienced that and how to best kind of handle that. Because even with nursing, they'll say, why'd you just go down in oxygen? And I guess just kind of some wording for that.
What, has anybody had this experience, and I would love to know kind of what, I will answer the question, but I do want to open it up to other people's experiences of in the home setting or the hospital setting, addressing, either putting oxygen on or taking oxygen off. How do y'all approach oxygen in this kind of care setting? We're thinking about a patient with progressive pulmonary metastases, right? Like pretty extensive, very close to the end of life. What have you guys seen?
I mean, I find it's very family specific in those kind of situations. It's what the family understands or how much education they've had from the get-go. You know, usually in all of our patients, we try to say oxygen is a lot of times for your comfort more than theirs. Sometimes it may cause them more discomfort because it's all this air blowing in their face. They don't want it. We're not going to look at their stats. We're going to look at how they're breathing, if they're comfortable, and manage it that way. And a lot of families understand that if you've talked about it from the get-go. I think it's hard if you've never talked about it, and at the end, you're going to try to discuss that. I mean, in my opinion, that would be a hard time to start that discussion. But
I agree 100%. That's how we approach it also, is begin the teaching when we first walk in about oxygen and really hone in on it at that point. And as things change, we're just there every moment of it. And it seems to give the family peace. It builds trust with them, and really developing a relationship and figuring out what their needs are. So I agree 100% with what she said.
Excellent. Thank y'all. And Ashley chimed in, anticipatory guidance. Yeah, talking about that. I think that some of the principles to keep in mind is that oxygen doesn't really treat dyspnea. Like if you took a patient who was really dyspneic and put them on a bunch of oxygen and didn't give them any opioids, they wouldn't feel better, right? So oxygen treats hypoxia, not dyspnea. We treat dyspnea through other ways. So uncoupling those is important. I think normalizing that oxygen is not required in this setting. I mean, you know, everything from like every time you go to the hospital for any reason to pop culture, TV shows, like everyone's on a nasal cannula. I feel like they feel like you can't be a patient unless you have a nasal cannula on your face. So that's what people think, right? Like, of course you would have oxygen. Why wouldn't you have oxygen? Every person who's a patient has oxygen. So I think we have to start that anticipatory guidance of saying, like, this is not just a given that you're on oxygen. And that's what y'all are talking about. So I love that. And then when you come to that really end, like Katie, the situation you were talking about, there is a reality that oxygen is sustaining. So oxygen treats hypoxia, but hypoxia is part of the natural pathway to like dying, right?
Right.
So if you keep somebody on oxygen, they're going to stay alive longer than if you turn it off, especially if the mechanism that they're dying from is like lung disease.
Yes.
So then that's goals based. Do we want that or do we not want that? I mean, I definitely have a kid. I have a kid in my mind. I remember from early days at Boston Children's. I believe she stayed alive for a week, breathing 4 times a minute because we left oxygen on her face. A week.
Yes.
I'm just like I think we're just like passively oxygenating her, and her little heart just had just enough to stay alive. She wasn't awake, she wasn't doing anything, but like she was not dying. So that's the kind of setting where I'm kind of like, maybe we should take this off. But again, only if it's goal concordant that this sort of like protracted dying process is suffering. If the family's like, thank God they're still here, and every minute I have with them, even though they can't wake up, leave the oxygen on. There's really not any advantage to it. And then somebody else mentioned the discomfort from the oxygen itself. I usually have like a 5-liter rule that if we go past 5 liters, that's probably blowing you away a little bit too much. So I just say, okay, well, we can go up to 5, and then that's it.
Well, yeah, he came in with a nasal cannula and it was going over 10 liters per minute. I was like, oh, let's, fix this. And he's like, oh my gosh, it doesn't burn anymore. Yeah, I know.
Yeah. I mean, and then you can always, a good trick to always have in your pocket with any of these things is the trial, right? So, okay, let's either do or undo something and just see how it goes and do a rapid reassessment, right? So let's turn the oxygen off for 10 minutes and just see how you feel without it on and reassess and see, we can always turn it back on, right? That's like a good thing to do so that we're not trying to make decisions without information.
As far as taking it off, I think it's really good to be able to, and Ashley and I share a patient that just went and are currently going through this right now with one, to definitely look at where the patient is at, what is ahead of them, and what kind of quality that they would have, and clarify the goals of care. And then once we have that, I think from my understanding, and if Stevia can call me later and give me a report so I could put in a clinical note for today, I've been touching base with her, is just like when we go out to the homes and compassionately extubate somebody, I think compassionately decreasing them while making them comfortable is just as important too, and takes a lot of anxiety off of the family. So I think that's an important.
Uh-oh. Christy, you muted yourself.
Would do it compassionately. It's very important.
I think, and that's a great point, that approaching it with care and recognizing that you may need more meds. It's not that the oxygen may be providing some sort of non-specific relief of their dyspnea. So you may need to kind of titrate up the opioids if you discontinue oxygen, and just being thoughtful about that approach. If the patient is unresponsive, that's usually when I go for the oxygen, especially if it's been a day and we're just kind of all right, we're all waiting. I'm we could take this off. Some people still can't tolerate it. And that, I work in our inpatient hospice facility frequently. And so, if I do round on a patient who's been unresponsive for 3 days and I notice we still have a nasal cannula on, I'll just gently suggest that we take that off. And some people it's easy, and some people it's still really challenging for the family to feel like you're de-escalating or removing anything that was previously helpful. So again, the anticipatory guidance of things that are helpful at some point then become unhelpful later. That's a really pertinent to food and fluids, right? But can also be pertinent to oxygen and respiratory support, or more intensive respiratory support. Like Christy mentioned, maybe we're taking the BiPAP off. Maybe we're taking the ventilator off of a trach patient. That's definitely a whole different element of de-escalation that we need to plan for, and probably is a topic of another discussion. But recognizing and anticipating the amount of dyspnea a patient's going to have when you do that, and making a good plan would definitely be something we'd want to do. And then how do you pick so then, how much is the right amount? I said is the amount that achieves the least amount that achieves the desired effect. But sometimes when we're talking about dyspnea, based on goals, patients would rather be over, right? So they would say, okay, try to keep me in the middle, but if you got to fall over, please fall over on the too medicated side. Please don't fall over on the not medicated enough and make me feel like I'm drowning and can't get my breath. And I don't want to ever feel like that again. That was torture. So I sometimes have to remember this patient may be a little over medicated, but I have to buffer against it is intolerable to drop down into the under medicated zone. So I have to live in the slightly over medicated in order to assure that. And that's a goals-based discussion, but that I accept that I may frequently have patients in the quote unquote over medicated if somehow I could magically know what their right amount of morphine is. And I take that on. Okay, so then the other thing we needed to talk about was double effect. And then I really do have to go deal with this patient. Double effect is the principle that if a medication, here we go, perfect. If a medication has two effects, right? One is that it relieves your dyspnea. The other is that it makes you breathe slower. if you're using it for the good purpose, then the less good purpose, it doesn't matter, right? Like, it's just kind of like a side effect we accept. It does not mean that we are not using it to hasten the patient's death or to make them stop breathing. That's not our intent of using the medication. Respiratory depression, hypopnea, low heart rate, low respiratory rate are side effects of the medication that we are using to control the symptom, either the pain or the dyspnea. So that's kind of what the doctrine of double effect is, that it's tied to the intent, not the outcome. I want you to know that because lots of people talk about it. I actually think we don't need doctrine of double effect, because in my experience, it's nice to have as an ethical and philosophical principle to fall back on. And specifically when you're talking to other people, I think it's really nice to sound very scientific and, there's this ethical principle of doctrine of double effect, but most of the time you're not actually doing this, right? Like, patients actually breathe more effectively if you control their dyspnea. They ventilate better when they're not in pain. So it's not like I want this, but I have to accept this. It's like, I want this. Oh, and then this also goes in the same direction. Look at that. Their breathing is actually better. And remember, these patients have some disease that they are dying of. So doing anticipatory guidance with the family, but also really making sure you're separating in your own mind, this patient is dying of some disease, and I am giving a medication to help control their symptoms. And those two things are on completely separate tracks. I'm not giving medicine that somehow makes them dying. I never, like, all the time, this is like top question people want to talk to me about, like, why is this patient going to die? What are they going to die of? And I think as a physician, that's a really helpful question, because that helps us figure out the prognosis, the timeline, and also like what it might look like, right? Like, you're going to die of airway compromise from a tumor is very different than you're going to gradually waste away from consumption by metastases, versus you're going to have like an acute bleeding event because you have liver failure. Like, I kind of need to know. Never is opioid toxicity going to be the thing that I say people die of. Never. 0% of the time. Because I don't do that, right? Like, maybe if I was an emergency room physician, I might see people who died of opioid toxicity. As a palliative care physician, I do not see people who die of opioid toxicity. I see people who die on opioids die from their disease. Yes? I know you can't say it to the other stakeholders need softened language and need all the hand holding, and we can talk about that. But I think holding it like within yourself so clearly, so that you can administer it, like, because you're either the prescriber or the literal administerer, right? Everybody in this room is in one of those two roles, probably, or at least close to it in some way. And so if we have fear and intimidation, we're not going to be able to do what we need to do.
Okay. Anything else, Emma?
No, now it's time for the thing. I've gone
Yes.
long.
But we want to thank you so much and really appreciate your expertise and experience, as well as everyone for participating and bringing these real life examples. It's so helpful and inspiring to hear the discussion and thoughts. Okay, Stacy, take it away to wrap us up with some mindfulness, please.
Okay, I decided to go a little bit different this time. I'm gonna share with y'all something. It's an ancient Hawaiian practice for forgiveness, ancient Hawaiian practice for forgiveness meditation practice. And it's called the Ho'oponopono. Ho'oponopono. And I'll send Maggie a thing to add to the presentation so she can put it at the end. Ho'oponopono. Very quickly, there was a Hawaiian therapist. His name was Dr. Lin, and he cured. And they did studies based on the cure rates, decreased morale, and employee turnover rate. That where he cured an entire ward of criminally insane patients without ever meeting them. And what he did was he would go in his office and he would lock the door and he would open up their file, picture them in his mind, and he would say he would do this practice. He would say the mantra. So I just chose to do this because I feel like not only are we tend to be, just as people and practitioners, hard on other people, but we tend to be hard on ourselves. So when you're doing this forgiveness technique, call to mind a relationship maybe that you'd like to heal or bring healing or forgiveness to. but keep in mind that that may be just for yourself. So as I go through the thing, and it's super simple, and you can keep it in the front of your mind, but it's to kind of give somewhere where you want to bring a deep connection of ease between you. In the Hawaiian practice, they did it in for family healing as well. So the first one is I'm sorry. It's going to be I'm sorry. Please forgive me. Thank you, and I love you. And when you're saying you're saying sorry to maybe it's something that you know that you did, or maybe it's something that you don't know that you did, or maybe it's something that you failed to do. Just kind of saying that I'm sorry, and taking ownership of whatever it is that you have and wherever this forgiveness things, whether it's for yourself or someone else. And then please forgive me. And the forgiveness is maybe it's coming from that other person, maybe from yourself, maybe from the universe or from God. Also the thank you, maybe you're thanking your body, maybe you're thanking God, maybe you're thanking that person, maybe you're thanking yourself, whomever. And then the I love you is super important. And kind of just saying I love you to that person. Maybe I love you to the air you breathe. I love you to God or the universe, but just each of these things. So we'll kind of do a quick little practice, but saying these things, and then when you're saying them, to really mean it. So I just wanted to give a quick overview, and we just have about 3 minutes left, but I'm going to use, usually I finish up early, but I'm going to use probably all of these 3 minutes. So I want you just to, if you want to turn off your camera, you can put your feet on the ground and kind of just center yourself and picture yourself as you breathe in, picture some golden light coming in through your heart, and opening up your heart and thinking about where you'd like to have some peace or forgiveness or relationship, whether it's someone else or maybe with yourself. And just picture that air, just picture that fresh air kind of going in and opening up, and picture that golden light coming through you, infusing your heart, giving gratitude and love and compassion for yourself, for all the wonders in your life. And then picture that person in front of you. And if it's yourself, picture yourself in front of you. Imagine that golden light overflowing from your heart and pouring it out to that person. And then beginning with the I'm sorry. Say I'm sorry to that person. I'm sorry. Or if there's something that you know you did, and maybe you don't even know what you did, just saying I'm sorry. Owning that piece, whatever your ownership is. Take a breath and picture that golden light going to that person. Then say to yourself, please forgive me, or to that person in front of you, please forgive me. Going back to that thing that you're sorry for, please forgive me. And then thank that person. Thank you. And breathe that in and out. And then say to them, with all that golden light and love coming from your heart, I love you completely. We'll do that one more time. I'm sorry. Please forgive me. Thank you. I love you. I'm sorry. Please forgive me. Thank you. I love you. Taking a nice deep breath in and out. And just knowing that you can picture that, you can do those 4 things very quickly, anytime, any place. We're at 1:30. I am today, just my own personal thing. I decided I was going to do this today for my teenage daughters, teenage grown daughters, right? Because I am sorry for anything I've done to hurt them, and I would love their forgiveness and remind them that I love them. But do this with anybody, but also be kind and forgiving to ourselves. And I'll send a link to Maggie with the prayer and any information. Any questions about any of this? We're right at 1:30.
Thank you so much, Stacy. We really appreciate it. It's always a good way to end the sessions. And just a quick reminder to everyone, we'll be sending the recording as well as the link to the recording and those resources that we talked about in the coming week. And our next session is going to be July 20th. Thank y'all so much for joining.
And thank y'all for everyone who participated and contributed. Take care.
And thanks again, Dr. Jones.
Thank you, Dr. Jones.
Thank you, Stacy. I needed that today. It's Christy.
Oh, my pleasure. Yeah, nice to put that in the front of our minds.
Yes. Y'all have a good one.
Take care.